All right, we're going to talk next about regenerative medicine, which is a large category talking about platelet-rich plasma and other technologies that I've been using. This started back for me in 2010 or 11, whenever Alaska was, and I saw this slide by Gary Hitzig that he showed where one side had PRP, one side did not. And even though I think this is very hard for me to believe, because in my opinion, it's not a question of, it's transection, it's tension, all those things. I don't think PRP is going to save you on an FUT closure. It did start my journey in this whole affair. And I started with using, I don't have any affiliation with any brands I mentioned here, Autologel, and I did it, injected the PRP before I made recipient sites, even before tumescence, and I still got really amazing results. And I was mixing one with 100 milligrams of fine powder ACell. And then a few years ago, I switched over to the Angel system, and Paul Rose came up with a nice little third-party comparison showing that this actually had a very high concentration of platelets. And a nice thing, I can draw about 120 cc's of blood and get a very high concentration of platelets and a large quantity as well. So, traditionally people talk about 1.8 to 2.5x platelet concentration being the favored amount. Recently I've heard 5x. Because I have the luxury of going to 5x, I usually do around a 5x, but depends on what I'm doing it for, and I'll explain more in detail how I use it. This wonderfully detailed graph talks about, for this particular system, how to concentrate, what percentages based on the amount you draw out and concentrate. Platelet-poor plasma is highly effective. I heard a lecture from an esteemed Indian colleague that he uses for the donor strip to be placed into it, and that's what I do now. I think there's less shock when the donor strip comes out. And a colleague of mine, Anthony Scalfani, actually looked at the activity of platelet-poor plasma and found it to be quite comparable to PRP. So I think platelet-poor plasma is very interesting. And I reviewed some interesting things about platelet-rich plasma for donor incisions, which for the next meeting in Bangkok, so I can't reveal it because it's been embargoed, but I just tease you with that. It's not my paper. In ACell, I use 100 milligrams of the fine powder. It comes in all different forms. This works very well. How do you do it? Of course, that's what you want to know. Again, don't worry about copying all this down. You will get a copy of this presentation. So for FUT surgery, I'm going to mix it down from the 120 milliliters down to about 14, 15 milliliters at 5x concentration. Mix that with 100 milligrams of fine powder ACell, and that's the extracellular porcine bladder matrix. I take 5 cc's of platelet-poor plasma, place into the donor incision after closure. I take 15 cc's where the initial strip is going into that in there, and then now I do it where I make my recipient sites, and then I inject the PRP and the ACell combo into the recipient bed subcutaneously, about 9 or 10 cc's of that. And the one trick here, though, you have to wear goggles, because after recipient sites, things squirt a little bit, so be careful. I use a 4x4 to hold it while I inject. The grafts are then coated with PRP and ACell. There's a natural question I've had people say, is it more difficult to place the grafts with this, with PRP and ACell in there? We have found it not to be that difficult. For FUE surgeries, it's the exact same thing. The only difference is I'm not using the platelet-poor plasma, since I'm not putting the strip, there is no strip into any, I place the graft straight into hypothermosol and ATP. You said, well, what do you do exactly? That's the second half of the talk, and I'll tell you how all of this comes together in a minute with that recipe. For without surgery, if I'm just using PRP as a standalone injection modality, then I just look at the area that I'm trying to cover. If it's a large area, I may be using about 30 cc's. If I'm doing a small area, I may use a higher concentration of 5x and doing about 15 cc's in there. Again, starting with 120 cc's of blood. I micropen and stimulate it, and I just do a single treatment with this, and it is mixed with ACell. How do I do it step by step? Here's a short video, about a minute long. I use Pronox, which is basically a breathable nitrous gas. Let me make sure this thing is playing. Sorry, I don't think it's, there we go. Oh, hold on. There we go. I use Pronox, which is a portable nitrous anesthesia for the patient to feel more comfortable. I do a ring block. I start with this 32 gauge 1% lidocaine into these little dots, so they don't feel the needle of the second layer, which is with 4% septicaine to 100,000. I finish the ring block. The nice thing with septicaine, not only does it not burn, but you don't need very much of it to create a good ring block. Here is my ACell. I use 100 to 200 milligrams of ACell, 15 to 30 cc's of it. I sort of divide the scalp into the areas based on how many syringes I have of the PRP. I inject subcutaneously across there and just divide the PRP across the whole area that needs to be injected. Here's just another view of the injection process, close up. And afterwards, I just sort of massage all that into it to make sure it's all evenly applied. Then I use this sort of micro pen set about 2.5 millimeters and inject. I usually time each area to be like 30, 45 seconds going across there, and then the end result should look like sort of a sunburn. So the key thing with PRP is it needs to be activated. If you are activating it surgically, recipient sites are enough to create the trauma to elicit the favorable response. If you're just injecting it, you've got to do something to activate it. You can use calcium gluconate, thrombin, etc. I feel that mechanical activation is more effective. And this is the start of my journey. Initially, when I did a gentleman, the middle one you can see he's not had a great result, and then I added the PRP and ACell on the second pass, saw a much better result. There's a gentleman here, again, not as much density that he would have liked. I added the PRP and ACell, and they served as their own controls. So I just started noticing there was so much more density on the second pass, and it could have been just the fact that I had more grafts there, but really it was a much more consistent growth, and this was in 2010, 2011. It really changed my thinking. And this is just standalone PRP injections showing some improvement in the thickness of the hair in different parting ways. So the last part of the talk is using liposomal ATP and hypothermosol as a medium. So for the grafts, I'm going to tell you how I do it in a minute. So for me, these four things are the cornerstones of how what I do for all my patients. I personally believe today that you really need all these technologies to get a more consistent outcome. One of my colleagues out of Brazil, what is his name? Man, I'm blanking his name. What's that? From Belo Horizonte. Who's? What? Pichon, thank you. Yeah, he does these, he's a genius. He wrote this like 100-page chapter in my book. Just really incredible thinker, but he does something where he does long hair transplants, FUT style, measures the hair mass index right afterwards, and then looks at what percent grows, and he finds that there's something he calls a personal growth index, where if you have the same surgeon and team and the growth is 80%, you grow 80% every time. Personally, I believe that with these regenerative techniques, you can overcome some anatomic restrictions. Of course, that has not been supported through any kind of level 1 series of studies, but it's just something I've seen anecdotally over the years. So I like to use this in every single case. I believe they're critical. So, the ATP you heard from Craig's talk earlier on, with the hypothermosol is meant to stabilize the sodium potassium ATP pumps, so there isn't the graft loss, the graft viability is improved. I've been using this since 2014. What I've noticed adding it 3 years after starting PRP and ACell is that the grafts even look less traumatized, they look finer, they grow faster. So I'm very, very pleased with this addition to my surgery, whether it's FUT or FUE. So this is how I use it. If I take 50 milliliters of liposomal ATP, I divide it out, so there's going to be the 10 into 100 of hypothermosol, which is what it comes in. That's going to be for FUE grafts or for sliver dissected grafts. Remember, on the bottom of the screen you see that if it was an FUT, the initial strip goes into PPP, platelet-rich plasma, and then it moves into the ATP hyperthermosol, whereas the FUE grafts immediately go into it. Then secondarily, whether it's FUT or FUE, I have 40 milliliters mixed with 400 milliliters of plasma light that gets sprayed on the grafts. It gets sprayed post-operatively for the patient. I have them spray every hour while they're awake for the first 3 to 4 or 5 days. Jerry clearly believes that it's an important important component to. It's almost like CPR for the grafts. I do that for my patients. I've been very pleased with this combination. And then you see on the bottom of the screen is that the grafts are coated in the final sequence before placement with a little drop of PRP and ACell. So stem cells, I defer to Ken. He knows a lot more than I do about this, and there are a lot of people much more knowledgeable. I don't have much experience of doing adipose-derived stem cells for hair growth. I think sometimes there's a mixed result on it, but so far the techniques that I have alluded to have been very, very effective. So I love these. I talk to my patients and describe it as fertilizers for growth. And it's what actually motivated me to rewrite my first textbook, because I felt in 2010 when I wrote the first edition it was completely outdated because I added all these new techniques to it. I don't make any money on my book series. They all go to charity. Stops first, I think a couple volumes go to stop human trafficking in the world, so you're doing a good thing for the world. And the fourth volume goes to help with cicatricial alopecia research, which is a terribly disfiguring thing, and it's, as you heard from Vance also, it's a huge rise in the last few years. So I leave you with the idea that have a vision for what you want to do in life, and your being here is really your first step in that movement forward to hopefully a cool new adventure. So next up will be, I want all the faculty to come up here.